What are the key components of an effective mental health assessment in emergency settings, particularly when evaluating suicidal ideation? Answer: an effective mental health assessment in emergency settings requires a comprehensive approach that includes the following key components. Patient history: gathering detailed information about the patient's psychiatric history, including previous suicidal behavior, psychiatric diagnosis, and any history of substance abuse. Risk assessment tools: utilizing validated tools for suicide risk assessment, such as the Columbia Suicide Severity Rating Scale (CSRS) or the Beck Scale for Suicide Ideation (BSI). These tools help quantify the risk based on the patient's statements and behaviors. Mental status examination (MSE), conducting a thorough MSE that evaluates appearance, behavior, speech, mood, thought processes, and cognitive function. Support systems: assessing the patient's social support systems, including family, friends, and community resources that may mitigate suicide risk. Safety planning: developing a safety plan that includes coping strategies, emergency contacts, and access to resources for crisis intervention, such as the National Suicide Prevention Lifeline. Legal and ethical considerations: understanding the legal obligations surrounding patient confidentiality and involuntary holds under laws such as the Mental Health Parity and Addiction Equity Act (MHPA). Discuss the management protocols for acute psychosis and delirium in emergency settings. What pharmacologic interventions are commonly used? Answer: management of acute psychosis and delirium in emergency settings involves a structured approach focusing on both immediate safety and long-term care. Key components include initial assessment: quickly assessing the patient's mental status, including orientation, memory, and perception. Establishing a clear differential diagnosis to distinguish between primary psychiatric disorders and secondary causes, e.g., infections, substance use. Safety measures: ensuring a safe environment for the patient and staff. This may involve physical restraints or medications for agitation if necessary, while continuously monitoring the patient for potential harm. Pharmacologic interventions: antipsychotics. Medications such as haloperidol or olanzapine are commonly used to manage acute psychotic symptoms. Dosing should be carefully monitored, especially in elderly patients, to reduce the risk of adverse effects such as extrapyramidal symptoms. Benzodiazepines: these may be utilized for sedation in cases of severe agitation or anxiety, but caution is warranted due to the risk of respiratory depression, especially in patients with delirium. Non-pharmacologic interventions: implementing a calm and structured environment, engaging in reorientation techniques, and addressing sensory deficits can be effective alongside medication. Identifying underlying causes: clinicians must perform appropriate laboratory tests and imaging studies to rule out infections, metabolic imbalances, or substance use, adjusting treatment based on findings. In summary, effective management of acute psychosis and delirium involves both pharmacologic and non-pharmacologic strategies, requiring careful monitoring and an individualized approach based on the patient's needs. Mr. Anderson presents to the emergency department after suspected opioid overdose. What are the immediate steps you should take to manage his condition? Answer: upon presentation of a patient like Mr. Anderson suspected of opioid overdose, the following immediate steps should be taken: assessment and airway management. Conduct a rapid assessment of the patient's airway, breathing, and circulation. Next, if the patient is unresponsive and exhibiting signs of respiratory depression, e.g., shallow breathing, bradypnea, initiate airway management, including supplemental oxygen or intubation if necessary. Administer naloxone, Narcan. Naloxone is the first-line treatment for opioid overdose. Administering naloxone can rapidly reverse respiratory depression and restore normal breathing. The typical starting dose is 0.4 to 2 mg IV, IM, or subcutaneously, with repeated doses every 2 to 3 minutes if needed, up to a total of 10 mg. Continuous monitoring. Monitor vital signs closely for improvement or deterioration, as the duration of action of naloxone may be shorter than that of the opioid, necessitating additional doses. Obtain a history and conduct laboratory tests. Gather information regarding the type and amount of opioid consumed, previous overdose history, and any co-ingestions, e.g., benzodiazepines. Order toxicology, screening, and laboratory tests to assess metabolic status and rule out other conditions. Consider advanced airway management. If there is no response to naloxone, or if the patient is not adequately breathing after the first doses, be prepared for advanced airway management and possible further interventions. In summary, timely recognition and treatment of opioid overdose are critical for improving patient outcomes, focusing on airway management and the administration of naloxone. What are the common symptoms associated with substance withdrawal syndromes, and how should these be managed in the emergency setting? Answer: substance withdrawal syndromes can vary significantly depending on the substance, but common symptoms include opioids, symptoms: anxiety, agitation, sweating, nausea, vomiting, diarrhea, muscle aches, and insomnia. Management: opioid agonists, e.g. methadone, buprenorphine, may be used for symptomatic relief along with supportive care. Alcohol: symptoms: tremors, anxiety, agitation, seizures, hallucinations, and delirium tremens. DTS. Management: benzodiazepines, e.g. lorazepam, are the mainstay of treatment to prevent seizures and DTS. Additionally, thiamine should be administered to prevent Wernicke's encephalopathy. Benzodiazepines: symptoms: anxiety, agitation, seizures, and insomnia. Management: gradual tapering of benzodiazepines and the use of long-acting benzodiazepines, e.g. diazepam, can help alleviate withdrawal symptoms. Stimulants, e.g. cocaine, amphetamines, symptoms: fatigue, increased appetite, depression, and sleep disturbances. Management: supportive care is generally sufficient, as withdrawal symptoms are typically less severe. Management of withdrawal syndromes in the emergency department should focus on recognizing the symptoms early, providing appropriate pharmacologic treatment, and ensuring patient safety throughout the withdrawal process. How can emergency departments implement evidence-based protocols to enhance performance improvement and patient safety? Answer: to enhance performance improvement and patient safety, emergency departments can implement several evidence-based protocols: identification of areas for improvement, conduct regular audits of patient care processes and outcomes, identifying areas where performance is lacking, such as delays in treatment or high rates of adverse events, development of protocols, create standardized clinical pathways based on best practices and guidelines from reputable sources, such as the American College of Emergency Physicians (ACEP) and the Centers for Disease Control and Prevention (CDC). For example, implementing sepsis protocols can streamline care and improve outcomes. Metrics for assessment: utilize key performance indicators, KPIs, such as door-to-needle time for thrombolytics, patient satisfaction scores, and rates of hospital readmissions to assess the effectiveness of protocols. Training and education: provide ongoing education and training for staff on the importance of adherence to protocols, focusing on teamwork and communication skills, use of checklists and tools. Implement tools like SBAR, situation, background, assessment, recommendation, for standardized communication during handoffs and to reduce the risk of miscommunication. Conducting root cause analysis, RCA, when adverse events occur. Conduct RCA to identify the underlying causes and develop strategies to mitigate future risks. Through these measures, emergency departments can systematically improve performance and enhance patient safety. Explain the role of root cause analysis, RCA, in improving patient safety in emergency medicine. Answer: root cause analysis, RCA, is a structured method used to identify the underlying causes of adverse events or near misses in healthcare settings, including emergency medicine. The role of RCA in improving patient safety includes identifying system failures. RCA helps uncover systemic issues contributing to adverse events, rather than focusing solely on individual errors. For example, a medication error may stem from miscommunication during handoffs rather than a single practitioner's mistake. Data collection and analysis. The RCA process involves collecting data from various sources, including incident reports, patient charts, and staff interviews, to understand the sequence of events leading to the adverse outcome. Developing corrective actions. After identifying root causes, healthcare teams can develop targeted interventions to address these issues. Monitoring and follow-up. Following the implementation of corrective actions, ongoing monitoring is essential to evaluate the effectiveness of these measures and to ensure that improvements are sustained over time. Fostering a culture of safety. RCA encourages a culture of transparency and accountability where staff feel comfortable reporting errors without fear of punishment. What strategies can be employed to reduce medical errors in emergency departments? Answer: reducing medical errors in emergency departments is crucial for improving patient safety. Several strategies can be employed. Standardization of processes. Implementing standardized protocols and checklists for common procedures, e.g. trauma resuscitation, sepsis management, can minimize variability and reduce the likelihood of errors. Effective communication. Utilizing structured communication tools such as SBAR, situation, background, assessment, recommendation, ensures clear and concise information exchange among team members, particularly during handoffs and transitions of care. Medication safety initiatives. Implementing computerized physician order entry (CPO) systems with decision support can reduce prescription errors. Additionally, employing barcoding for medication administration helps prevent wrong drug errors. Team training and simulation. Regular team training sessions, including simulations of high-stress scenarios, can improve teamwork, communication, and decision-making skills, ultimately reducing errors during real events. Patient involvement. Engaging patients in their care can act as an additional safety net. Providing patients with clear instructions and encouraging them to ask questions can help identify potential errors. Incident reporting systems. Establishing robust incident reporting systems allows staff to report errors and near misses anonymously, fostering a culture of safety and enabling organizational learning from these events. By employing these strategies, emergency departments can significantly reduce the risk of medical errors and improve overall patient safety. What are the indications for the use of activated charcoal in emergency medicine, and what are the contraindications? Answer. Activated charcoal is used in emergency medicine to treat certain types of poisoning and drug overdoses. The indications and contraindications for its use are as follows. Indications: acute ingestion of toxic substances. Activated charcoal is indicated for the oral ingestion of certain toxins and medications if administered within 1-2 hours of ingestion, provided the patient is alert and can protect their airway. Specific substances. Effective for substances that are well absorbed by charcoal, such as acetaminophen, salicylates, barbiturates, some antidepressants, theophylline. Contraindications: unprotected airway. Activated charcoal should not be administered to patients with an altered level of consciousness or who are unable to protect their airway, as this increases the risk of aspiration. Ingestion of corrosive agents. Contraindicated in cases of ingestion of caustic substances, e.g. strong acids or bases, as it may not bind the toxin and can cause further harm. Bowel obstruction. Avoid use in patients with suspected gastrointestinal perforation or obstruction, as charcoal can exacerbate these conditions. Non-absorbed substances. Not effective for substances that do not bind to charcoal, such as alcohol, metals, e.g. iron or hydrocarbons. In summary, activated charcoal can be a valuable treatment for specific overdoses if used appropriately, considering the indications and contraindications to ensure patient safety. Discuss the role of performance improvement metrics in assessing patient outcomes and safety in emergency medicine. Answer. Performance improvement metrics play a crucial role in assessing patient outcomes and safety in emergency medicine. Key aspects include identifying areas for improvement. Metrics provide a means to evaluate the effectiveness of care provided in the ED, identifying gaps and areas that require enhancement. Benchmarking performance. Comparing metrics against national standards or peer institutions can help emergency departments gauge their performance and identify best practices. Types of metrics. Process metrics. Assess adherence to clinical protocols, e.g. time to antibiotic administration in sepsis cases. Outcome metrics. Measure patient outcomes including mortality rates, readmission rates, and patient satisfaction scores. Safety metrics. Evaluate the incidence of adverse events, such as medication errors or hospital-acquired infections. Implementing evidence-based practices. Utilizing performance metrics to develop and implement evidence-based protocols can improve care quality and patient safety. For example, tracking door-to-needle times for thrombolytics in stroke patients can lead to process improvements. Ongoing monitoring and feedback. Continuous tracking of performance metrics allows for timely feedback to staff, fostering a culture of quality improvement and accountability. In summary, performance improvement metrics are essential for assessing and enhancing patient outcomes and safety in emergency medicine, driving evidence-based practices and quality care. Explain the importance of evidence-based practice in emergency medicine and how it impacts patient care. Answer. Evidence-based practice is a fundamental approach in emergency medicine, emphasizing the integration of clinical expertise, patient values, and the best available evidence. Its importance includes improving patient outcomes. BP leads to better patient outcomes by ensuring that clinical decisions are based on the most current and robust research findings, reducing variability in care, reducing ineffective practices by relying on scientific evidence. BP helps identify and eliminate ineffective or outdated practices, ensuring that patients receive the most effective treatments. Enhancing clinical decision-making. BP equips clinicians with the knowledge to make informed decisions, fostering critical thinking and enabling them to navigate complex clinical scenarios effectively. Promoting standardization of care. BP supports the development of clinical guidelines and protocols promoting standardized care that improves consistency and safety across emergency departments, facilitating continuous learning. Engaging in BP encourages ongoing education and professional development, allowing practitioners to stay updated on the latest research and advancements in emergency medicine. Patient-centered care. BP emphasizes the importance of considering patient preferences and values, ensuring that care plans are tailored to meet the unique needs of each individual. In summary, evidence-based practice is vital in emergency medicine, significantly impacting patient care by improving outcomes, enhancing decision-making, and fostering a culture of continuous improvement. What are the clinical implications of hyperkalemia in the emergency setting, and what are the appropriate management strategies? Answer: hyperkalemia can lead to life-threatening cardiac complications. Key considerations include clinical signs. Look for ECG changes, peaked T waves, widened QRS and possible sine wave pattern, muscle weakness, and possible arrhythmias. Management strategies. Stabilization. Administer calcium gluconate or calcium chloride to stabilize the cardiac membrane, reducing the risk of arrhythmias. Shift potassium. Use insulin with glucose to drive potassium back into cells. A dose of 10 units of regular insulin along with 25 grams of dextrose is common. Remove potassium. Administer sodium bicarbonate if metabolic acidosis is present, and consider beta agonists like albuterol for additional potassium shifting. Elimination. If severe renal replacement therapy, dialysis may be required. Monitoring ECG continuously is crucial during treatment due to the risk of sudden cardiac events. Describe the evaluation and management protocols for a patient suspected of having an acute ischemic stroke. Include the role of thrombolysis. Answer: the management of acute ischemic stroke is critical for minimizing neurological damage. Evaluation. Utilize the FAST method. Face drooping, arm weakness, speech difficulties, and time to call for help. Conduct a rapid neurological assessment using the NIH stroke scale, NIS. Imaging. Obtain a non-contrast CT scan of the head to rule out hemorrhagic stroke before considering thrombolysis. Management protocols. Thrombolysis. Administer intravenous tissue plasminogen activator (EPA) within 4.5 hours of symptom onset if no contraindications exist, e.g. prior hemorrhage, uncontrolled hypertension. If TPA is contraindicated or if there is an extensive arterial occlusion, consider intra-arterial thrombolysis or mechanical thrombectomy is indicated. Post-management. Initiate secondary prevention strategies, antiplatelet therapy, statins, and control of risk factors like hypertension and diabetes. Time-sensitive intervention can dramatically improve outcomes in acute ischemic stroke. Explain the criteria for diagnosing sepsis and the initial management steps required in the emergency department. Answer: early recognition and management of sepsis are crucial to improve outcomes. Diagnostic criteria according to the SOFA sequential organ failure assessment score. A suspected infection with a greater than or equal to 2-point increase in SOFA score indicates sepsis. Look for signs such as altered mental status, tachycardia, hypotension, and lab abnormalities, e.g. leukocytosis or leukopenia. Initial management steps. Fluid resuscitation. Administer at least the AAG of crystalloids within the first hour. Broad-spectrum antibiotics. Start IV antibiotics promptly after obtaining cultures, blood, urine, etc., but ideally within 1 hour. Vasopressors. Initiate norepinephrine if the patient is hypotensive despite adequate fluid resuscitation monitoring. Continuous monitoring of vital signs and reassessment of fluid status is vital to guide further interventions. Discuss the protocols for managing adult cardiac arrest, emphasizing the importance of early defibrillation and post-resuscitation care. Answer: effective management of cardiac arrest is time-critical and involves several steps. Immediate actions. Activate emergency response and initiate high-quality CPR immediately, 30 compressions to 2 breaths while calling for an AED. Defibrillation. Early defibrillation is critical in cases of shockable rhythms, ventricular fibrillation, pulseless ventricular tachycardia. Deliver the first shock as soon as the AED is available. Follow up with CPR for 2 minutes before rechecking the rhythm. Post-resuscitation care. Focus on optimizing ventilation and circulation, maintaining normothermia, and achieving early cardiac catheterization if the arrest was due to ischemia. Use targeted temperature management to prevent neurological impairment in eligible patients. Comprehensive care following resuscitation improves the likelihood of favorable neurological outcomes. Outline the management strategies for a patient with burn injuries, including the assessment of burn depth and the importance of fluid resuscitation. Answer: proper management of burn injuries involves several key steps. Burn assessment: classify burns by depth. First degree, superficial, e.g. sunburn; the second degree, partial thickness, blisters; third degree, full thickness, Eschar. Estimate the total body surface area (EBSA) affected using the rule of nines or London-Browder chart. Fluid resuscitation: for burns greater than 10% TBSA in adults, initiate fluid resuscitation using the Parkland formula. 4 ml per cent x body weight Ag, administered over the first 24 hours. Monitor urine output. Goal: 0.5 A or assess adequacy of resuscitation. Wound care and pain management: provide analgesia and clean and dress burns using appropriate sterile techniques. Consider referral to a burn center for extensive burns. What are the unique considerations in assessing and managing pediatric trauma patients compared to adults, and what is the significance of using appropriate equipment? Answer: pediatric trauma assessment requires specific adaptations, anatomical and physiological differences. Children have a larger head-to-body ratio, making them more susceptible to head injuries. Their circulatory systems can compensate for significant blood loss, so vital signs may not reflect the severity of injuries. Assessment techniques: use age-appropriate assessment tools, e.g. Pediatric Glasgow Coma Scale. Obtain history from caregivers using the Pediatric Assessment Triangle for quick evaluation. Equipment considerations: ensure that all equipment, e.g. endotracheal tubes, defibrillator pads, is appropriately sized for children to avoid complications during interventions. Use pediatric-specific algorithms and drug dosages based on weight for medication administration. What is the systematic approach to evaluating a patient presenting with acute abdominal pain in the emergency department? Answer: a thorough evaluation of acute abdominal pain follows several key steps. 1. History taking. Use the OPQR-ST method: onset, provocation, quality, radiation, severity, time, to gather detailed information about the pain. Obtain a thorough medical, surgical, and medication history. 2. Physical examination. Perform a focused abdominal exam assessing for tenderness, guarding, rebound tenderness, and bowel sounds. Consider examining for signs of peritonitis and distension. 3. Laboratory and imaging studies. Order a CBC, BMP, and liver function tests, as well as urinalysis if indicated. Use imaging studies, ultrasound, or CT scan as necessary based on clinical suspicion, e.g. appendicitis, cholecystitis. 4. Differential diagnosis. Keep a broad differential including appendicitis, pancreatitis, bowel obstruction, and perforation. A systematic approach aids in accurate diagnosis and timely management of acute abdominal pain. Explain the management of a patient presenting with suspected opioid overdose. What are the key interventions to reverse its effects? Answer: opioid overdose is a medical emergency requiring rapid intervention. Recognition: signs include altered mental status, e.g. stupor or coma, respiratory depression, and pinpoint pupils. Immediate management: airway management. Ensure airway patency and provide supplemental oxygen as needed. Naloxone administration. Administer naloxone, Narcan, intranasally or intramuscularly 0.42 mg, repeating doses every 2-3 minutes if necessary until respiratory function returns or emergency assistance arrives. Supportive care. Continuously monitor vital signs and provide ventilation support if respiratory effort does not improve. Consider additional interventions if the patient does not respond to naloxone, e.g. possibility of co-ingestions. Timely administration of naloxone can be life-saving in cases of opioid overdose. What are the critical steps in the management of a patient experiencing anaphylaxis in the emergency setting, and how do you differentiate it from other allergic reactions? Answer: anaphylaxis is a severe, life-threatening allergic reaction requiring immediate management. Recognition: look for rapid onset of symptoms within minutes, such as urticaria, angioedema, difficulty breathing, and hypotension. Distinguish it from other allergic reactions by the severity and speed of onset. Immediate management. Epinephrine. Administer intramuscularly 0.3–0.5 mg for adults, 0.1 mg for children as the first line of treatment. Positioning. Place the patient in a supine position and elevate the legs if they exhibit hypotension. Adjunctive therapies. Administer antihistamines, e.g. diphenhydramine and corticosteroids, e.g. methylprednisolone, to help manage symptoms and prevent biphasic reactions. Provide oxygen and consider fluid resuscitation for patients experiencing significant hypotension. Discuss the approach to managing a patient presenting with acute psychosis in the emergency department. What are the key considerations for safe evaluation and treatment? Answer: managing acute psychosis requires careful evaluation and a structured approach. Initial assessment: conduct a thorough history and mental status examination, assessing for risk factors, e.g., substance use, medical history, evaluate for any potential medical causes, e.g., infections, metabolic disorders that may contribute to the psychosis. Safety considerations: ensure a safe environment for both the patient and staff, considering the use of restraints if necessary for aggressive or dangerous behavior. Monitor vital signs and level of consciousness closely. Pharmacological management: administer antipsychotic medications, e.g., haloperidol or olanzapine, to help stabilize the patient. Dosing may vary based on the severity of symptoms. Consider benzodiazepines if the patient exhibits severe agitation or anxiety. Referral and follow-up: consult with psychiatric services for further evaluation and management. Ensure appropriate follow-up care and safety planning before discharge. The management of acute psychosis in the emergency setting requires a balance of rapid intervention and consideration for patient safety and potential underlying causes. What are the immediate management steps for a patient with a suspected pelvic fracture, and what complications should be anticipated? Answer: in a patient with a suspected pelvic fracture, immediate management steps include stabilization. Apply a pelvic binder or sheet to provide mechanical stabilization of the pelvis, reducing hemorrhage and stabilizing the fracture. Fluid resuscitation. Initiate IV fluid resuscitation to address potential hypovolemia due to bleeding. Pain management. Administer analgesics to control pain while monitoring vital signs closely. Imaging. Obtain pelvic X-rays or a CT scan to assess the fracture and rule out associated injuries. Anticipated complications. Hemorrhagic shock due to bleeding from pelvic fractures or associated vascular injuries. Organ injuries. Potential injuries to the bladder, urethra, or major vascular structures. Thromboembolic events. Increased risk of deep vein thrombosis due to immobilization. How does the assessment and management of trauma differ in pediatric patients compared to adults? Answer: the assessment and management of trauma in pediatric patients differ from adults in several key ways. Anatomical differences. Children have different anatomical proportions, larger heads, softer bones that affect injury patterns and mechanisms of injury. Physiological responses. Children may compensate for significant blood loss longer than adults, leading to sudden decompensation. Assessment techniques. Use age-appropriate scales, e.g., Pediatric Glasgow Coma Scale, for neurological assessments. Fluid resuscitation. Pediatric patients require different fluid resuscitation calculations, e.g., 20 mg of isotonic crystalloid for fluid boluses. Guidelines. Use specialized pediatric trauma protocols and engage pediatric trauma teams when available for optimal care. What are the steps in managing a patient with a chemical burn, and what specific considerations are needed for different types of chemical agents? Answer: the management of a chemical burn includes immediate decontamination. Remove the patient from the source of the chemical exposure and remove contaminated clothing. Irrigation. Rinse the affected area with copious amounts of water, usually 3 euro minutes, using saline if water is not available to dilute and wash away the chemical. Assessment. Evaluate the depth and extent of the burn, documenting findings. Specific agents, acids, e.g., hydrochloric acid. Irrigate for a longer duration to neutralize effects. Alkalis, e.g., sodium hydroxide, require thorough irrigation as they can penetrate deeper tissue layers. Organic chemicals, e.g., gasoline, do not use water. Instead, cover with a dry dressing and consult toxicology for specific recommendations. Guidelines. Follow protocols specific to chemical exposures and consult poison control centers for advice on particular agents. What are the key components of evaluating and managing a concussion in a trauma patient, and what criteria determine return to play or activity? Answer: the evaluation and management of a concussion include initial assessment, conduct of thorough neurological evaluation, including a symptom checklist and cognitive testing, symptom monitoring, assess for common concussion symptoms, e.g., headache, dizziness, confusion, and perform serial evaluations to monitor changes. Rest and gradual return. Recommend physical and cognitive rest initially, gradually introducing light activities as tolerated. Return to play protocol. Follow a stepwise progression. Light aerobic exercise, sport-specific exercises, non-contact training drills, full contact practice, and return to play. A player should not return until they are symptom-free at rest and during exertion, and they should be cleared by a healthcare professional. Guidelines. Adhere to the latest consensus statements on concussion management, ensuring comprehensive follow-up care. Describe the assessment and management principles for a patient with blast injuries, including the types of injuries commonly encountered. Answer: assessment and management of blast injuries include primary assessment, evaluate airway breathing, circulation, and neurological status, noting any signs of respiratory distress or hypovolemic shock. Types of injuries. Primary blast injuries result from overpressure waves causing barotrauma to air-filled organs, e.g. lungs, gastrointestinal tract. Secondary blast injuries result from projectiles or debris impacting the body. Tertiary blast injuries occur when the individual is thrown by the blast wave, resulting in blunt trauma. Quaternary blast injuries include burns, inhalation injuries, or crush injuries from structures collapsing. Management: stabilize and resuscitate as needed, closely monitoring for respiratory and circulatory complications. Obtain imaging studies to assess for internal injuries, especially pulmonary contusions or organ lacerations. Discuss advanced hemorrhage control techniques used in trauma care, including the indications and application of tourniquets and hemostatic agents. Answer: advanced hemorrhage control techniques include tourniquets. Indications: severe extremity hemorrhage that cannot be controlled with direct pressure application. Place 2-3 inches above the injury site, tighten until bleeding stops, and secure. Note the time of application. Hemostatic agents. Types: powdered agents, e.g. Quickclot, Celux, that promote clotting. Indications: used in conjunction with direct pressure in severe hemorrhage cases, especially in inaccessible areas. Application: apply directly to the bleeding site, ensuring adequate pressure to facilitate clot formation. Guidelines: follow the latest trauma management guidelines for the appropriate use of these techniques, particularly in pre-hospital settings. What are the key considerations in the management of open fractures in trauma patients, and what protocols should be followed to minimize complications? Answer: management of open fractures includes immediate care. Control bleeding with direct pressure and stabilize the fracture using a splint. Avoid excessive manipulation of the fracture site. Irrigation and debridement. Perform thorough irrigation, saline or sterile water of the wound in the emergency department to remove debris and reduce infection risk. Surgical debridement may be necessary based on the extent of soft tissue injury. Antibiotic prophylaxis. Administer appropriate antibiotics, e.g. cephalosporins, to prevent infection, especially for Gustillo-Anderson grade I and II fractures. Tetanus prophylaxis. Ensure tetanus immunization is up to date. Booster every 10 years or after 5 years if the wound is high risk. Guidelines: adhere to the latest trauma management protocols to minimize infection and optimize healing. What are the immediate steps in managing a patient with suspected spinal cord injury following trauma? Answer: management steps for suspected spinal cord injury include cervical spine stabilization. Apply a cervical collar and maintain spinal immobilization throughout transport and assessment. Primary survey, conduct a rapid assessment of airway breathing, circulation, and neurological status, paying particular attention to motor and sensory function. Imaging studies, obtain imaging CT or MRI to evaluate for fractures, dislocations, or compression of the spinal cord. Neurological assessment, use the ASIA, American Spinal Injury Association classification for initial neurological evaluation. Steroid administration, consider high-dose methylprednisolone for acute spinal cord injury within the first 8 hours to reduce inflammation and improve outcomes. Guidelines: follow the latest protocols for spinal cord injury management, emphasizing the importance of immobilization and rapid transport to a specialized center. How can burn depth be accurately assessed, and what are the implications of the different burn depths on management and prognosis? Answer: burn depth can be classified into first-degree burns affect only the epidermis, presenting as red and dry. Management typically includes symptomatic relief, e.g. analgesics, moisturizing lotion. Second-degree burns, superficial partial thickness, involve the upper dermis, presenting with blisters and pain. Management includes wound care and possibly topical antibiotics. Deep partial thickness, extend deeper into the dermis, resulting in white or mottled skin, and may require surgical intervention or grafting if healing is delayed. Third-degree burns, extend through the dermis and into deeper tissues, appear leathery or charred, and are typically painless due to nerve damage. Surgical intervention, e.g. excision and grafting, is usually required. Implications: accurate assessment guides treatment decisions, the need for surgical intervention, and prognosis regarding healing times and potential complications. What mental health considerations should be addressed in trauma patients, particularly in those with significant injuries or complex trauma? Answer: key mental health considerations include assessment of psychological impact, screen for signs of acute stress disorder, PAST, or post-traumatic stress disorder, PTSD, using validated tools, G. PCL5. Support systems evaluate the availability of social support and coping mechanisms among patients. Referral for counseling. Refer patients to mental health professionals for trauma-informed care and therapy options, especially if they exhibit ongoing distress or impairment in functioning. Education and follow-up. Provide education about the normal psychological responses to trauma and encourage follow-up appointments for ongoing support. Guidelines incorporate mental health assessments into trauma protocols to address the psychological sequelae of traumatic injuries, ensuring comprehensive patient care.